And welcome back. Let's open up our conversation by putting a kind of a clear line between how people get hurt and why they suddenly feel ill. Okay, so trauma is really the physics of force, right? We're talking broken bones, lacerations, blunt impact, while medical emergencies, by contrast, are the real biology of dysfunction, right? A heart that misfires, lungs that can't keep pace, an immune system that turns on itself. Most calls you'll answer will fall kind of into one camp or the other. But never forget that the two can actually collide together. A driver who suffers a heart attack may crash moments later. A hypoglycemic patient can collapse and fracture a wrist. So this chapter really focuses on taking a tour of the medical side of that specific coin, right? Showing you how to read subtle clues, build a working clinical diagnosis on the fly, and kind of get the patients to the right resources quickly. So mastering these principles does more than just satisfy, again, our educational requirement. It really sharpens the clinical instincts that let us spot a disaster before it announces itself with these flashing red flags. Now, the first competency you see is medicine, right? It's the foundation of everything else we do in non-traumatic care, okay? It asks you to apply fundamental knowledge at the bedside in a way that turns assessment findings into action. So think of it as your mental toolbox, right? Pathophysiology, that explains why the patient looks the way they do. Pharmacology, that tells you what interventions are safe. And clinical reasoning, that guides which problems you tackle first. So when you walk into a room and instinctively elevate the legs of a septic patient, or coach an anxious asthmatic through pursed lips breathing, before you ever reach for albuterol, you're demonstrating this competency in real time, right? This chapter really reinforces that an EMT is not just a stretcher bearer, right, but an active medical provider whose decision begins the chain of survival. Now, medical overview, okay, so this competency. So this is like your roadmap for turning, again, a simple, vague complaint into a clear treatment and transport plan. It starts with recognizing the nature of illness. So this is what system is failing in the body. Is it the respiratory, the cardiac, endocrine? You'll learn to pull that answer from dispatch notes, the environment itself, and just like the first general impression of that patient. And then from there, the standard demands an organized assessment, okay? A primary survey to rule out any life threats, targeted history using your sample and OPQRS mnemonics, and a focused head-to-toe exam as it's indicated. But assessment is only half the game. You must also decide how to move the patient, right? Do we stay and stabilize, or should we package and rapidly transport? Should we go by ground transport to get definitive care, or does a rural location and a ticking STEMI clock make the air medical transport a smarter call? Finally, destination matters, right? A stroke may survive the extra miles to a thrombectomy capable center, far better than it survives a delay in reperfusion, right? So your judgment here literally buys brain, heart, and lung tissue the time that it needs. The third competency really kind of focuses on infectious disease, sharpening your pretty much your clinical eye and your personal defenses, so to speak. So you need to think about your awareness, right? So know the difference between an infectious disease and a communicable one, and recognize red flag symptoms like a fever, rash, night sweats, productive cough. That's going to raise your index of suspicion, right? And then your assessment and management. You want to apply standard precautions, or when warranted, your airborne and contact precautions. Gather a travel history. Has the patient been outside the country in the past 21 days? And then look for specific syndromes that our textbook really highlights, like influenza, herpes simplex, HIV, hepatitis, meningitis, tuberculosis, pertussis, MRSA, COVID, Ebola. So it's important to understand that also the transmission routes, right? Droplets versus bloodborne versus airborne. So your PPE really matches the threat. Then remember that the public health piece of this all, quick notification of the receiving facility, documentation, immediate reporting of exposures really protect not just you, but every provider and every patient that's going to follow. So when you can weave infection control like really smoothly into your routine, you fulfill that in spirit, right? Not just the letter, but of this entire competency. So before we really dive into the specific disease states, I like to frame the whole chapter by, asking a student to picture two very different but kind of overlapping stories, okay? Trauma, right? Trauma is the language of physics. You have velocity, force, penetration. Medical emergencies really speak the language of physiology, right? Cells deprived of glucose, coronary arteries starved of oxygen, bronchioles squeezed shut by inflammation. On any given call, you may meet a pure example of one or another, yet the reality is often kind of messier, right? A driver whose blood pressure collapses from sepsis may drift across the center line and roll that vehicle. A skateboarder with head trauma might seize en route to the hospital because of an undiagnosed glucose disorder. So the first mental checkpoint is, am I looking at trauma, medical, or is it both? And then staying flexible enough that your working diagnosis, working clinical diagnosis can change the moment new information appears. So the textbook does a good job reminding us not to let dispatch information also just lock us into tunnel vision, right? But you can use it as a loose roadmap while we keep scanning for those unexpected clues, right? That open-minded stance is what really separates a provider who just records vitals from one who truly practices medicine in the field. Now, the first cluster of medical calls you'll meet kind of centers around oxygen delivery and circulation, okay? Your respiratory complaints, whether it's an asthmatic flare-up, emphysemic exacerbation, or maybe bronchitis, that's just getting worse, right? These usually announce themselves with an audible distress, wheezing, tripod positioning, pursed lips breathing. Now, your job is to decide quickly whether to simply position that patient and just give them some oxygen. Is that enough? Or whether the patient needs more advanced bronchodilators or ventilatory support, A cardiovascular crisis may follow close behind that, right? The heart can scream for help as crushing substernal pain, or kind of a whisper, kind of vague epigastric discomfort, especially in our and that's kind of especially in our diabetic and female patients. Because remember that a silent MI, myocardial infarction, can kind of masquerade as a shortness of breath or just fatigue. Next, would come to your neurological exam, right? Or the neurological, rather, realm of emergencies. You have your seizures, your strokes, syncopal episodes. With strokes, every minute genuinely is the brain. For large vessel occlusions, the window for a thrombolytic treatment can close in as little as 6 hours. So. And then we have gastrointestinal issues, appendicitis, pancreatitis, diverticulitis, conditions where patients often can't really localize the deep visceral pain, but so your serial abdominal exams and attention to orthostatic blood pressure changes, that's going to really become the diagnostic compass for these patients. This slide kind of shifts to the focus on the systems that aren't really flashy, but they feel the real. It fills the real EMS call logs. Okay, so and that could be like your urologic emergencies. Often arrives kidney stones. And these patients, are just in extreme pain, unable to find any type of comfort, sometimes vomiting from the pain. So quick recognition and judicious analgesia can turn a miserable ride into kind of a tolerable one. You have your endocrine issues. Most commonly we're going to deal with diabetes. That kind of forces us to think about the biochemistry Is the altered patient hypoglycemic? Are they hyperglycemic? Maybe they're septic with, coincidental like high sugars, right? A finger stick glucose is, worth its weight in gold in this situations. We have hematologic disorders, though less frequent, they can be dramatic. You have sickle cell crisis that presents with kind of excruciating like bone pain, or hemophiliacs whose minor trauma can't clot, and the person can bleed out. It's also important that these calls remind us that not all bleeding is visible. Sometimes it's the lab values that bleed. So now we reach the body's kind of interpersonal drama. So it's like the relationship with the outside world, okay? And that's going to be your immunologic emergencies, like anaphylaxis. That shows really how a perfectly normal immune system can like overact with lethal speed. Recognizing it's important recognizing biphasic reactions, and giving early epi often determines a patient's survival. We have toxicologic cases, that is going to challenge our reasoning and detective skills. The unconscious teenager might have, overdosed, inhaled some type of fumes, or mixed household cleaners together. We have our behavioral and psychological crisis, the broaden the definition of what's a life threat. A suicidal patient on a bridge, that demands every bit as much as clinical attention as a patient with chest pain. And our calm verbal de-escalation becomes as critical as any drug we could possibly give. We have gynecologic complaints, whether it's like a ectopic pregnancy or PID. This requires sensitivity and solid obstetric mindset, because a hemorrhage can hide in the abdomen long before vital signs are going to tip you off. Now that we've reviewed the major categories of medical emergencies, it's really time to shift our attention towards how we assess these patients. Now, medical patients don't always look as sick as they actually are, right? Some can speak clearly, they can walk by themselves, yet be experiencing really a life-threatening internal kind of process. That's why we rely heavily on a patient's history, their symptoms, and any subtle findings that we might find. And it's not just what we can see externally, right? And now, as an EMT, your goal is to build an index of suspicion, right? By connecting the patient's complaints with your knowledge of physiology. You need to keep in mind that patients may present with like overlapping conditions, and many of them have emergencies we've discussed. Many can have emergencies we've discussed can have atypical presentations. Especially in our like elderly or our immunocompromised patients. So this transition really marks the beginning of your critical thinking as an EMT, where you go beyond following just a checklist and begin really synthesizing your findings into a working clinical diagnosis and treatment plan. Now, starting with your patient assessment, our patient assessment for medical calls, they're going to share a lot of similarities with your trauma assessments, but there's going to be an important difference, and it's that the focus is not on the mechanism of injury, but instead on the nature of illness, or the NOI. So with medical calls, we really depend more on what the patient tells us and what we can infer from like the environment, the patient's signs and symptoms, and their history. You'll focus on identifying the patient's chief complaint, observing signs and symptoms, and listening for clues in their just overall story. Now, many times a well-conducted assessment is going to reveal far more than a simple, quick, like visual scan. A good example is this, your chest pain might be cardiac in origin, but it could also be a pulmonary embolism, just acid reflux, maybe even like a panic attack. A detailed assessment is really your primary tool in ruling in or ruling out these possibilities. So your effectiveness as an EMT is really often defined by how accurately you assess your patient and whether you catch those like subtle red flags that can indicate something much more serious. Now, once once on the scene, it's kind of tempting to rely on that dispatch information to kind of shape your initial approach. but it can be definitely misleading. Okay, now while dispatch gives you a starting point, your actual decision should be based on what you observe and what the patient actually communicates to you. So don't fall into like having tunnel vision by assuming what's reported is the full story. An example, a call labeled as a fall patient could actually stem from, a syncopal episode or maybe a stroke or hypoglycemia. A traumatic injury might be secondary to a medical problem. So you really have to stay open to changing your clinical impression as that new information becomes available. You should also be prepared, to gather a thorough and accurate medical history. Patients might not always know how to describe their symptoms clearly, and family members or bystanders can actually be critical sources of that information. You can also look for environmental cues, medications, mobility aids, oxygen cylinders that can really help piece together the full clinical picture for this patient. Now, some of the biggest challenges in EMS arise not from like the medical complexity, but rather from the patient's behavior. Patients may be uncooperative, they can be agitated, intoxicated, or just mentally unstable. So they actually may lash out you verbally or physically. So your role is really to remain calm, respectful, and by all means professional, really regardless of how that patient is presenting. You really never want to label or dismiss someone as just, they're drunk or a frequent flyer, okay? So a patient who often calls EMS may still experience a new or serious condition. Now, also there's something called bias, right? Bias, even if unintentional, can cause you to miss like time-sensitive diagnoses, like strokes or overdoses. So you're really there to advocate for your patient's safety and care, not just to pass judgment. So building a rapport, staying non-judgmental, and just communicating clearly, they're not just soft skills. They are clinical tools that are going to help you assess and care for patients just more effectively. Your demeanor also plays a role. It's going to set the tone, and it can influence whether a patient is going to cooperate with treatment or become resistant to you, which again in turn will impact the overall outcome of that patient. So before you ever touch a patient, you need to ensure that the scene is safe, right? So you're gonna do a scene size up, and again, it's not just checking these little boxes off. It's really an evolving process that continues throughout the entire call. In our medical emergencies, hazards might not be immediately visible like they are in a trauma scene, but they still exist. So. For example, you might encounter an infectious disease. You might have environmental hazards like the patient's like a hoarder, so you're having to like jump over obstacles to get to the patient, or maybe even just agitated patients or family members. So in any of those cases, you should always use standard precautions, including your gloves, possibly mask or eye protection, really just based on the scenario or situation that you find yourself in. You need to determine how many patients are present. Now, while medical calls typically involve a single patient, you must be ready for that multiple people being exposed to the same condition, such as like a carbon monoxide poisoning or a foodborne illness. Then evaluate the nature of illness. Ask yourself, what are the patient's complaints? What signs or symptoms are present? This is going to help you establish your index of suspicion, which is just your level of concern for potential serious underlying issues. Lastly, you got to decide pretty early on whether additional resources like ALS, fire, law enforcement are required or needed, and then you need to activate them and call them without delay. Now, your primary assessment is really your opportunity to rapidly identify life threats and determine whether the patient requires immediate intervention or just rapid transport. Okay, this begins with your general impression, which is often formed in the first few seconds. Is the patient alert? Are they unconscious? Are they breathing adequately? Do you hear gasping sounds? Do they appear pale, sweaty, warm? Are they talking? You really need to trust your instincts in these situations, but again, verify those instincts with objective assessments. If the patient is unresponsive or appears critical, you need to perform a rapid scan to identify, obvious severe bleeds, compromised airway, signs of shock. And then assess the level of consciousness, starting with our APU scale. Is the patient alert? Do they respond to verbal stimuli, painful stimuli? Are they unresponsive? Again, this is going to tell you a lot about the patient. For instance, an alert patient likely has, a patent airway, perfusing circulation. But even if they're awake, you don't just stop there. You want to continue on your assessment and identify those, subtler signs of compromise. Your primary assessment isn't about, a detailed diagnostics. It's about quickly determining, is this patient stable or do they need rapid intervention and transportation? Now, after you've assessed the patient's mental status, you want to immediately evaluate the patient's airway and their breathing. For our conscious patients, you ensure their airway is open and unobstructed. Okay, listen for abnormal sounds like gurgling, snoring, or stridor, and really just watch for the chest rise and fall. You want to assess respiratory rate, depth, quality. Are they breathing too fast, shallow, irregular, labored? Is the breathing inadequate, right? Or if the patient shows signs of distress, you got to consider your treatment plan, administering oxygen, really based on your protocols. For unconscious patients, your airway assessment becomes even more sensitive and critical. You're going to use your manual techniques you learn, like the head tilt chin lift, the jaw thrust maneuver, depending on the scenario, just to open up the airway. Be prepared to suction if it's needed. Maintain the airway with an OPA or MPA. Now, in your medical patients, respiratory compromise is, again, one of the more common and dangerous presentations. And that early recognition and oxygenation for that patient can save lives. It's important to remember, in pre-hospital care, oxygen is one of the few medications that we can carry that's going to treat a wide range of conditions, from asthma to stroke, to shock. So utilize it when it's necessary. Now, we can continue on here focusing on the breathing, and it kind of introduces more on the topic of oxygen therapy and the indications. So you should really apply oxygen to patients who are in shock, right? They're in shock, they're having difficulty breathing, or they present with, oxygen saturations, under 94% on the pulse oximeter. In patients who are breathing but inadequately, you might start with a non-rebreather mask at 15 liters, while a patient with poor respiratory effort or shallow breathing, they may require ventilatory support with positive pressure ventilations via a bag mask ventilation device or a bag valve mask. So it's really important to remember, oxygen is a treatment, not a reflex, right? Not every patient needs it. Okay. Someone who has a minor complaint and SpO2 at 98%, that likely oxygen administration won't benefit them. But however, don't hesitate to intervene aggressively when signs of hypoxia, cyanosis, altered level of consciousness, when those symptoms and signs appear. In our unconscious patients, again, like I talked about, we want to be ready to insert that BLS airway adjunct, the OPA and MPA. And if they're not breathing effectively, positive pressure ventilations. The goal of our primary assessment is really to identify and correct any threat to oxygenation before they progress to the point of a cardiac arrest. Now, after confirming your airway and breathing are covered, we want to move on to our circulation, right? In a conscious patient, we're going to assess circulation by checking a radial pulse. We want to note the rate, the rhythm, the quality. Is it fast? Is it slow? Is it strong or thready? Is it irregular or regular? Also, evaluate the patient's skin color, their temperature, their moisture. A normal patient should be pink, warm, and dry. So if you have a pale, cool, diaphoretic patient, that may indicate shock or poor perfusion. In patients with darker pigmentation, assess the mucous membranes, right, such as the inner eyelids or the lips, and you're just looking for signs of pallor or cyanosis. In our unconscious patients, you really need to palpate the carotid pulse. It's a central pulse, it's stronger, it's more reliable in these critical situations. Now, as you scan the patient, this is where you want to look for any type of external bleeding, especially from the torso and the extremities. A severe bleed, should have been caught already, but that's going to be a life threat that takes really priority over the airway, and breathing. And you need to address it almost immediately. So this step in the primary assessment really allows you to determine whether the patient has adequate perfusion status or if some type of immediate intervention and transport is more indicated. Now, our final step of the primary assessment is to make that transport decision. So based on what you've seen so far, you just got to ask yourself, does this patient need immediate transport, or can further assessment and interventions happen on scene? So a high priority patient, those include those who are unconscious, altered level of consciousness, airway or breathing circulation, airway or breathing issues, show signs of circulatory compromise, like your shock or severe bleeds. So if any of these apply, you should really rapidly prepare the patient to transport and complete that further assessment en route to the hospital or rendezvous with ALS. Because it's important to remember, patients can quickly deteriorate, and any delay in moving can have, long-lasting serious consequences. So if you're ever uncertain, it's usually safer to err on the side of caution, and just transports. Because, while not every sick patient needs to be rushed to the hospital, with going code 3 or lights and sirens, identifying when rapid transport is appropriate is really a core decision-making skill that you'll develop with the appropriate experience and training. Now, after completing your primary assessment, and again, you've already managed any life threats, you're going to start gathering a patient history. Okay, so I typically classify this in your secondary assessment. But I digress. For many of your medical patients, the history is like a very important diagnostic type tool. Now, I say diagnostic and diagnosis a lot, but just know that when I'm referring to that, it's all about clinical impressions. Okay, so it's more about your clinical diagnosis. So, because again, only your doctors are going to be able to diagnose. So we're just kind of taking all the signs and symptoms, and we have an index of suspicion of what this could be. So what's our clinical impression of what this potential issue is, and that's how we're treating them, right? We're not going to say to a patient, hey, they're having a myocardial infarction, but all of our signs are pointing that way. We're going to treat it as if that is what's happening, but we can't diagnose it to the patient or on our medical, on our PCRs. That being said, we really want to kind of go to our chief complaint and kind of dig into the details of that chief complaint and see if it kind of aligns with any of their sample questions. But we are going to utilize two mnemonics, the sample and OPQRST. Okay, sample is a good way just to gather information about the chief complaint and the actual patient themselves, where OPQRST in this context is primarily used to create a pain profile, and it's like a baseline vital for pain. That way we can kind of look at trends, but it can, we'll talk about this later, but it can be adapted to kind of look at difficulty breathing and respiratory issues, but we'll kind of stick to the primary use, which is going to be pain. Now, in terms of the overall sample, right? So one of the most important parts is to ask the patient about their history related to their specific illness. When did symptoms begin? What makes them better or worse? How have they changed over time? You're looking for patterns, right? Ask follow-up questions like, has this ever happened before? What was done last time to treat it? If the patient's unconscious, though, you're not going to just stop, right? You want to gather information from bystanders, from family members. Maybe there's medication bottles around, or maybe there's clues on scene, right? You want to do everything you can to gather information. The family actually might know about recent health changes or, critical past medical history. Bystanders might have witnessed the events leading up to the emergency. And you also want to survey the scene for clues, right? Is there, pill bottles? Are there oxygen cylinders, medical devices, and any notes that can provide insight into the patient's baseline health? In the absence of a trauma, really your ability to gather and interpret history, that's going to become like the primary determinant of appropriate care. Now, continue on your history by obtaining a full sample and OPQRST assessment. So again, sample stands for signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading to the actual emergency. When you're asking about medications, don't just ask about like prescribed medications. You want to ask about over-the-counter meds, any supplements they're taking, any herbal supplements they're taking. Older patients, especially, maybe on multiple meds, and in those cases, it's often easier just to bring the entire set of medications to the emergency department. It's also important to ask, are they compliant with their medications, right? So they could be prescribed a bunch of things for different illnesses, but sometimes they just forget to take their meds. Sometimes they don't want to take the meds. Sometimes they, ran out of the meds and they haven't been able to go get it refilled, their prescription refilled, or they don't have access to it because they can't drive to the pharmacy, or perhaps, financially they can't afford it. So you definitely need to ask those follow-up questions as well. When you're using OPQRST, you want to ask the patient, describe the onset of symptoms, what provokes or palliates them. Now remember, provokes means what makes it worse, palliate means, or palliation means what makes it better. The quality of any discomfort or sensation. So best way to do that is, describe the discomfort or pain in your own words. Whether there's any radiation, so if they are, I like to throw in a couple more. So I like radiation, right? I like to do region, radiation, recurrence. So region, point to me with one finger where the most pain is. Does the pain go anywhere else? So that's the radiation. And then recurrence, from the moment it started, has it progressively gotten worse, better? Has it been constant? Does it come and go? And then severity is going to be, the symptoms. How do the symptoms feel on a scale of 0 to 10? 0 being no pain, 10 being the worst. Depending on your department and your PCR, it might be like a 1 to 10 scale, but 1 being no pain, 10 being the worst. So you just have to quantify it to the patient, and that'll kind of help them decide what it is. But I always like use 0 for now. But it doesn't matter. And then lastly, timing. When did it start, and whether it's and then what I like for this one is get an exact time, because again, they could say, it started this morning, it started last night, or it started a couple hours ago. So get a specific. A couple hours ago, does that mean it was 7 a.m.? So again, just kind of narrow that down a little bit more, because a person might not always be aware of their spatial time awareness kind of situation. But overall, these questions really give you a kind of a structured way to explore that patient's chief complaint and in great detail. And it's often the most revealing part of your assessment. You also want to document these findings really carefully and relay them during your radio report and your hospital handoff, because they're going to be vital for the continuity of care for that patient. Now, your secondary assessment, diving more into it, again, we're going to provide more of a focused or detailed look at the patient's condition, and that's largely dependent on the chief complaint, clinical presentation. This step really takes place on scene, or it could be en route to the hospital. It really just depends on the patient's stability, transport urgency. In our stable, conscious patients, the secondary assessment is often limited to a targeted or what we call focused physical exam, really just based on the chief complaint. Listening to breath sounds in a patient with respiratory distress, maybe looking at their chest for any abnormalities, checking for pedal edema in patients, with maybe a potential heart failure. But in our unconscious or unresponsive patients, you really have to perform that head-to-toe exam, even if it's just a medical emergency, because they can reveal like hidden injuries, maybe devices like insulin pumps, implanted pacemakers or defibrillators, or you might see signs of overdose or infection. So really the goal here is to uncover additional findings that weren't immediately obvious during your primary assessment, and to just collect the clues needed to support or refine your working diagnosis. And you also want to match the depth of your exam to the clinical situation, but never skip it when it's indicated. Now, during the actual physical exam, you want to start at the head and move downward in kind of a systematic manner. And we're going to cover this a lot when we get to trauma, but you're going to check the scalp, the face for trauma, asymmetry, any lesions. You're going to examine the eye for a pupillary response, for conjunctiva, for moisture and pallor. You're going to inspect the ears and nose for drainage, for bleeding, any type of deformity. Assess the mouth for loose teeth, bleeding, swelling, cyanosis. We're going to move down to the neck, look for jugular vein distension, tracheal deviation, accessory muscle use, subcutaneous emphysema. And again, all that could indicate, respiratory issues or cardiac issues. We're going to expose the chest, look for if there's any paradoxical chest movement, listen for lung sounds. We might look for medication patches, surgical scars, implanted devices. Moving down, we're going to go to the abdomen, palpate for, we're going to palpate for tick, look for distension, rigidity, ecchymosis, guarding, pulsating masses. Look at the pelvis for priapism, incontinence, bleeding, signs of pregnancy. We're going to evaluate femoral pulses. We're going to go to the lower extremities. Again, look for, dependent or pedal edema. We're going to look for sensation sensation motor and control. CMS, circulation motor and sensation. Excuse me. Check see if they can. Do they have any type of loss of function in their feet? Check the pedal pulses. We might look for track marks between the webbings of the toes. Look in the arms for shunts, fistulas. Track marks in the antecubital fossa area. Check radial pulses, medical alert tags, things of that nature. Flip them on their back, especially we always want to check this for unconscious and altered patients, but check their back again. Same things you'd find in the chest: paradoxical chest movement, sucking chest wounds, maybe ulcers like pressure ulcers, sacral edema. You can check lung sounds on the back as well, but. Really, we're going to go really in depth in trauma on this, so I wouldn't get too caught up on it. But every part of this exam really can uncover important information that it's going to inform and kind of guide your treatment plan. The final step of your secondary assessment is just collecting vital signs. You started this really in your primary assessment, and it's kind of dependent on how many resources you have on scene. But at this point, you should have really gotten a full set of vitals, because vitals are really objective, measurable indicators of the patient's current condition. Okay. First, you want to assess the pulse. Note whether it's fast, is it slow, regular, irregular, strong, weak. Evaluate respiratory rate, their depth, the effort, the rhythm. Again, this should be, when you're looking at the respiratory rate, which we're going to talk about this more in respiratory emergencies, but you got to be kind of discreet while you're assessing it, because patients will change their breathing pattern if they tell them. So pretend like the best way to do it, like I've found, is like pretend you're taking the patient's pulse to really avoid influencing their breathing pattern. Blood pressure, right? Blood pressure should be measured manually at least once for accuracy. So again, you're going to use a manual blood pressure, either upper or lower extremity, typically upper. Use a pulse oximeter to assess O2 saturations, and when appropriate, take a blood glucose reading if it's indicated. Especially if there's any concern of altered level of consciousness, neurologic symptoms, or in any diabetic patient. Now, all of this data really gives you a baseline against which you can kind of compare future readings. So don't just take these numbers and move on. You really got to analyze them in the context of the full patient picture. Vital signs often shift before outward symptoms appear. So it really makes them a critical early warning system for clinical deterioration. Now, once the initial assessment and treatment are complete, your work is like far from over, right? The reassessment phase is your ongoing process to monitor the patient's condition and ensure that the interventions are actually working. You want to begin by repeating the primary assessment, recheck mental status, airway, breathing, circulation, reassess the chief complaint. You need to note whether the symptoms improved, did they worsen, did they stay the same. You want to repeat vital signs every 5 minutes if the patient's unstable, and every 15 if they're stable. You want to check all interventions. Reassess the oxygen delivery, right? If you're assisting with ALS, check IV lines, make sure they're still intact, they haven't blown. Look at bandages, your splints, and really any treatment that's provided. Just make sure it's still functional and working. And again, you want to document all your findings, any changes, and any actions that were taken. Because again, this documentation is very important because it's not just for the chart, it protects the patient by allowing the hospital team to see the full progression of care. And most importantly, don't let the reassessment become passive, right? Use it to actively evaluate trends, anticipate deterioration, and just update transport decisions if it's needed. As an EMS provider, we often catch declines in status during these reassessments that weren't really apparent during your initial exam. Now, most medical emergencies can't be definitively treated in the pre-hospital setting. Our job as EMTs is to manage symptoms, stabilize the patient, and to transport them to a facility that's really equipped to provide that definitive care. Now, many patients will require like advanced testing, like imaging, labs, some type of special consultation. And that's just not possible really at this point in the field. Now, we can assist with some medications in limited cases, like nitro, albuterol, aspirin, oral glucose, but these must be administered, under medical control and only when they're within our local protocol and scope. So you really familiarize yourself with your agency's like standing orders. Always document what was given, when, under whose direction. You may also use, an automated external defibrillator, so your AED. So in cases of cardiac arrest, which again, it remains one of the most impactful interventions in EMS. So our focus again is not to diagnose, right? It's rather just to recognize critical conditions and just provide the best supportive care that's possible until that patient reaches higher level of medical intervention. Now, scene time in medical calls can vary depending on the patient's overall stability. So generally though, medical scene time is longer than a trauma patient's because there's often more need for history gathering, medication review, and a detailed assessment. But if the patient is critical, unstable, shows signs of deterioration, like altered level of consciousness, respiratory distress, signs of shock, you really have to limit your scene time to 10 minutes or less, okay? Now, in these cases, you want to focus on a rapid assessment, necessary life-saving interventions, and quick packaging for transport. When the patient is stable, you may want to spend a few more minutes gathering history, checking their living conditions, collecting important items like medication bottles, because again, these clues are invaluable at the hospital and can really make a major difference in their diagnosis. The key here is just judgment, right? So don't delay transport without a clear reason, and just always reassess those priorities as your situation is evolving. Now, transport priority, again, isn't just about distance. It's really about urgency and just clinical appropriateness. So if the patient has a life-threatening condition, then, rapid transport using your lights and sirens, code 3, that is going to be justified. But again, lights and sirens only save a few minutes at most, okay? And they come with significant risk, increased chance of traffic collisions, okay? So only use them when, those minutes are gonna matter. For our stable patients, a non-emergent transport is often the safer and just more appropriate choice. Now, as you gain experience, you're gonna develop better instincts about, high versus low priority transport decisions. Again, typically, your altered level of conscious patients, shock, severe respiratory difficulty, unrelieved chest pain, that should push you towards high priority transport. But if the patient responds well to treatment and stabilizes on scene, emergency transport might not be needed. So if you do choose to use lights and sirens, be prepared to justify the decision in your documentation, especially in the case of an adverse, event. Now, there are two primary modes of transport in EMS, and that's ground and air. Okay, so ground transport is pretty much the standard, most commonly used. That's staffed by EMTs and paramedics in our ambulances that are equipped for basic and advanced life support. They're really efficient, they're safe, usually sufficient for most medical emergencies, particularly in our urban or suburban areas. Ground crews also tend to be more familiar with local hospitals, have shorter activation and loading times. So in most cases, the use of air transport is not necessary unless the situation involves like significant distance, time-sensitive intervention, or requires transport to a specialty center that's not reachable by ground in an appropriate time frame. So really think about like rural areas, prolonged extrication, patients requiring specialized, pediatric or cardiac care. But regardless of the mode of transport, your decision must be based on clinical needs, not convenience, okay? So really always coordinate with dispatch, medical direction when considering these air resources to ensure the best outcome for that patient. And we'll talk more about EMS operations and transport decisions a little bit later on in the semester. Now, in terms of that air transport, again, we're going to cover more later on, but let's kind of talk a little bit more right now. Again, it's less common for medical patients, but again, specific conditions where it's appropriate can be potentially life-saving. These air medical units are typically staffed by critical care nurses, flight paramedics, and are best suited for patients in remote areas, again, or needing specialized care, like a pediatric trauma center, a STEMI center, stroke center, burn center, or when ground transport times becomes dangerously long. Now, typically about 30 minutes or longer, but that could be due to like traffic situations or prolonged extrication, things of that nature. But as we're going to discuss, certain criteria have to be met to call in for air transport. And one of those issues is the weather. Does the weather meet the ability for that helicopter, that air transport to come and land? But we'll talk about that. So again, another reason why you would use air transport would be like a patient having a STEMI, so that's ST elevation myocardial infarction, and they needing a cardiac catheterization, right? So they need a STEMI center, so they have to actually have heart surgery. A stroke patient going into a stroke patient going to a stroke center, or a trauma patient with multi-system injury needing to go to a trauma center. Now, air transport itself can really significantly reduce the time to that definitive care. But again, it comes with logistical challenges. It's very high cost and it's limited availability. So you always have to weigh the total response and transport time of air versus ground. And again, just consult medical direction when making that call. If air transport will not meaningfully reduce the time to treatment, or if ground ALS is faster, it's best to just stick with the ground crew, right? The goal is always timely and appropriate care, not just fast care. Now, destination selection, again, that's just as critical as the mode of transportation, okay? Now, while it's often appropriate to take the patient to the closest emergency department, Certain medical conditions require, those specialized facilities. Patients experiencing a stroke, they should go to a stroke center. And those are equipped with, interventional neurology services. Similarly, heart attack patients, they need to go to a facility that can do, a PCI or a cardiac catheterization. Your region may have specific policies for STEMIs or trauma bypass that direct patients to designated centers. If the patient arrests en route, right, or if instability develops, you may need to divert to the nearest available emergency department. So really just use judgment, communicate with medical control as indicated, and just explain your rationale to the patient or the family. Always consider the patient's preference, but you really have to prioritize clinical necessity first, okay? Your transport decision really affects the overall outcome. So make it based on the full clinical picture, not just the convenience or just habit. So now we move into one of the more high risk but kind of overlooked areas in EMS, and that's your infectious diseases, okay? An infectious disease is any medical condition that's caused by an organism that's growing or spreading within the body, okay? Now, a communicable disease is one that can be spread between people or species. In the pre-hospital setting, it's not always obvious who is infected, which is why we always apply, standard precautions to every single patient. In the first section, we'll really review the common infectious diseases, the signs and symptoms, what to watch for, the routes of transmission, and really how to protect both you and the patient. Your assessment of potentially infectious patients really begins just like any other call, with the scene size, primary assessment, secondary assessments, history taking, symptoms like fever, vomiting, a cough, a rash, that should always raise your index of suspicion. And don't forget to ask about, recent travel or exposures to others who might have been sick. These small little details often provide the first clue of a more serious communicable disease. Okay? When in doubt on these calls, you want to mask the patient with a surgical mask and use your full personal protective equipment and BSI until you can rule out something more concerning. Your history and assessment really become important in these infection cases and after completing your scene size up, your primary assessment, ask detailed questions using that sample and OPQRST mnemonics. Don't forget to document any fevers, travel, rashes, vomiting, respiratory symptoms, and really ask the patient these follow-up questions to kind of determine if it's an infectious disease. Has the patient been around anyone who's been sick? Has anyone in the household traveled internationally in the past 2 weeks? Does the patient live in a congregate setting like a nursing home or a shelter? These are all red flags for potential outbreaks. As you take vitals, pay attention to the patient's temperature, respiratory rate, oxygen saturations. These will often change before the patient shows those clear outward signs. Even something as simple as a dry mucous membrane or flushed skin might start to point you to a serious condition, like sepsis or influenza. So as always, wear your appropriate PPE, protect yourself, your partners, and just follow your agency's exposure control plan for disinfection, decontamination after the call. Now, management with these suspected infectious diseases really begins with the same priority as any call, and that's airway, breathing, and circulation. But it's it's layered with kind of a strict focus on provider safety. Okay. First, we want to address any life threats identified in your primary. Administer oxygen, apply positive pressure ventilations if indicated, and provide circulatory support as indicated. But always remain vigilant. Infectious patients often appear stable until they start to decompensate. Okay. And also in these situations, as with anybody, empathy always matters, okay? So these patients, again, may feel scared, isolated, and are gonna benefit from that calm reassurance that you can provide. You want to try to keep them warm and comfortable, especially if they have a fever or chills, okay? Again, use PPE as appropriate for these situations, gloves, eye protection, and 95 mask when it's indicated. Really, and again, just follow your agency's exposure control plan and never skip steps in that post-call decontamination, okay? That includes, properly disposing of contaminated materials, cleaning the rig before you place it back in service. Because really protecting your crew and yourself is just as important as caring for a patient. And every exposure you avoid is a potential infection that has been prevented. In EMS, just understanding the public health context of infectious disease is essential, okay? An epidemic is defined as a sudden increase in the number of disease cases in a population that exceeds, normal expectations. A pandemic, on the other hand, that occurs when that disease spreads across multiple countries or continents, impacting a large population on a global population, okay? Now, unfortunately, we've seen this firsthand recently with COVID-19. But pandemics can be caused by new strains of influenza, the coronavirus, or other types of like novel pathogens. So these diseases tend to spread rapidly because there's little or no immunity in that specific population. And often there's no vaccine at first. So EMS providers are really frontline responders in these events. That means you really have to stay informed. You have to follow CDC local guidelines and be prepared to adapt protocols for PPE, triage, and transport. Okay, your role during a pandemic may extend beyond patient care to include, community surveillance, public education, and just infection control enforcement. Influenza. So influenza, also known as just like the flu, that's again one of the more common communicable diseases you're going to encounter as an EMT. Now, while it's often viewed as just kind of like viewed as a mild illness, it can be life-threatening, especially for our very young patients or our very old, or just those with chronic conditions and have compromised immune systems. Influenza is primarily an animal-type respiratory virus that mutated to infect humans, and it impacts its impact varies year to year based on the circulating strain. It's transmitted through aerosolized droplets. Okay, that's usually from coughing, sneezing, or even just like speaking with a very wet voice, so to speak. It can also spread actually via direct contact with like nasal secretions, contaminated surfaces. We have something called H1N1 that's used to be called, it's also known as swine flu. And again, that's just one example of a flu variant with deadly potential. Patients may present with fever, chills, fatigue, body ache, sore throat. I'm sure most of you have experienced this before, but because symptoms overlapped with other respiratory infections, including COVID and pneumonia, you always have to maintain that high index of suspicion and just follow airborne precautions when it comes up. Always mask the patient and yourself to prevent that spread. So typically your patient will either get an oxygen mask or a surgical mask. You should always put on your properly fit tested N95 mask. Now, because influenza is spread through the respiratory route, again, EMS providers, we have to use strict personal protective equipment protocols. And that means at minimum, this includes, gloves, eye protection, and your HEPA or N95 mask. When it's feasible, though, place a surgical mask on that patient to reduce the chance of droplet transmissions. Because for these aerosol generating procedures, like suctioning, CPR, bag mask ventilations, you want to use this maximum protection to try to help yourself out. Now, one of the more effective preventative steps is getting your annual influenza vaccine, your flu vaccine. which again only protects not only you but also your patients. Okay, the flu virus does evolve constantly, so the vaccine is reformulated each year, really based on the CDC, which is the Center for Disease Control, and the WHO, which is the World Health Organization surveillances. So EMS providers are strongly encouraged to stay up to date with all their immunizations, but if you don't want to, that is your prerogative. You just have to usually sign like a declination form saying you deny it. Depending on where you work, you might just have to be during flu season, for example, have to like wear a mask and have like a little sticker of shame put on your badge. Now, it's also important to remember that viruses can survive on surfaces for days. So you really need to clean your equipment and your environment thoroughly after each call. You know, influenza may be common, but it can still be deadly, right? And your vigilance is really what help you stop it from spreading to another patient, or just stop the spread entirely. Now, herpes simplex virus, okay, this is HSV. This is a actual common infection with approximately like 80% of people actually carrying the virus just asymptomatically, okay, so that's without symptoms. Now, symptomatic infection, that's often presents with what we call vesicles. These are like small, like fluid-filled like blisters, typically located on the lips or the genitals. Now, while these outbreaks are often mild, in the immunocompromised, the elderly, the very young patients, herpes actually can lead to severe complications like pneumonia or meningitis. The primary mode of transmission is just close personal contact, typically sexual contact, especially when the lesions are active, so they're actually being symptomatic. So now, while herpes simplex is not typically a high-risk infection for EMS providers, standard precautions are still essential. Gloves, proper hand hygiene, and again, avoid direct contact with any open lesions. That's usually enough to kind of protect yourself. It's also important to recognize that that patients may be experiencing pain or embarrassment associated with an outbreak, and a professional, again, non-judgmental approach can go a long way with just building trust. Now, your role, again, is primarily supportive of these patients, manage discomfort, maintain infection control, and just transport when it's necessary. HIV, okay, so this is the human immunodeficiency virus. So this virus is responsible for what we call acquired immunodeficiency syndrome, which is AIDS, okay? What it does, it weakens the body's immune system, and it makes the patients vulnerable to infections that would otherwise be harmless, right? Because while AIDS remains incurable, though recent news suggests that it is kind of on the curable side, or it has very, very good treatments. We're progressing to a full-on cure. Modern treatment regimens have enabled many patients to live like near normal lifespans, right? Importantly, HIV is not easily transmitted in an EMS setting, okay? The virus does require direct entry into the bloodstream or the mucous membranes, okay? This typically is through exposure to infected blood, semen, vaginal fluids, or breast milk, okay? So any of that has to actually either get into your mouth or into your blood through like an open wound on yourself. So it is fairly uncommon for that to happen. So it's far less contagious than like hepatitis B, for example. For EMS providers, needle stick injuries, blood splashes to the eyes, nose, or mouth, or open wounds, that's going to pose the biggest risk, okay? Again, there's no definitive vaccine against HIV, so your standard precautions, gloves, careful handling of sharps, that's going to be your best defense. HIV should never trigger fear or panic, though, okay? There are a lot of stories, especially back in the day, where we would find out a patient has HIV and some EMTs would just flat out refuse to treat them. And that's not appropriate in this field. Okay, you're there to pass non-judgment. You're there to treat the patients. But again, you should just reinforce the importance of taking universal precautions on every call. Okay, and that's again treating every bodily fluid as if it is contaminated, to be hyper aware of bodily fluids, so there's a less likely chance of getting that exposure. Now, one of the challenges of HIV is that many patients don't show symptoms, particularly in the early stages. So again, that's why universal precautions on every single call so important. You won't often know who is infected, and that just doesn't apply to HIV. That's any type of communicable disease. So again, always wear your gloves before making patient contact. Never recap needles or handle any, or if you do have to handle sharps at all, you just have to be careful. If you do experience any potential exposure, a needle stick, mucous membrane, contact with blood, notify your infectious disease officer immediately and seek medical evaluation. Okay, your shift is essentially over if you have an exposure. Okay, you need to transfer care, and you immediately need to wash, clean, disinfect that area of which you were contaminated, and again start this whole process. Okay. Early administration of the post-exposure prophylaxis, again, that may significantly reduce the likelihood of infection. Okay, your agency really should have a written protocol for post-exposure incidents, and you should know how to follow it, right? And also, try your best to avoid, stigmatizing language when dealing with HIV patients. Maintain professionalism and really just protect the patient's dignity at all times. It's really important to not let fear of exposure prevent you from providing that compassionate, high-quality care. Okay, because with the right precautions, your risk of contracting HIV on the job just is extremely low. Now, hepatitis refers to the inflammation of the liver. Okay, it's often caused by a viral infection or exposure to toxic substances. Now, among EMS personnel, hepatitis B and hepatitis C, those pose the greatest risk due to their bloodborne transmission. Hepatitis B is especially concerning because it's far more infectious than HIV, and it can survive on to services for up to a week. So symptoms of viral hepatitis can include fatigue, loss of appetite, fever, body aches. And eventual telltale signs can be jaundice, and that's when you have a yellowing of the skin or the eyes, because again the inflammation of the liver, just where your liver is important for filtering out your blood, so you're gonna have a backing up of toxins in your blood, and it shows as yellowish color to your skin and eyes. But unfortunately, again, there's no definitive way in the field to know whether a patient is hepatitis, or if their specific hepatitis is contagious, right? But the good news is that a vaccine does exist for hepatitis B. Again, and again, this is more of an optional vaccine to get, but again, it is strongly recommended for providers to get it. Okay, yeah. So again, it's not often required to receive it. But not everyone develops a full immunity after the vaccination, so follow-up testing is going to be needed. But regardless of your vaccination status, you should always, again, use your standard precautions, use gloves, eye protection, and just treat everybody's blood, every patient's blood and bodily fluids as if it is potentially infectious. Now, continuing on, it's important to understand how different types of hepatitis are transmitted. So this is important to know. Hepatitis A specifically is through what we call oral fecal contamination, and it's often via food or water, and is typically short-lived. And it's just like it sounds, basically it's found in a person's fecal matter, and somehow gets inside of you via the mouth, so by either eating or drinking contaminants. Now, no, it's not like you're actually it's more like someone has it that's preparing your food. They use the restroom, they didn't wash their hands, and they start preparing your food, and that's kind of how you get it. At least one way to do it. Now, in contrast, hepatitis B and C, those are spread through blood and bodily fluids. And again, that may lead to a chronic infection, liver failure, on extreme cases, cancer. Now, these types can be transmitted even with, when the carrier is like showing no signs of the illness. And again, that's what really makes them dangerous to the healthcare providers. Okay. So always use caution, again, with any type of needles, any broken glass or blood-soaked materials, especially in like motor vehicle crashes or just like violent incidents, because you might have blood like all over the place. Patients with a history of intravenous drug use or multiple hospitalizations, they're going to be at a higher risk. If you are exposed, though, through a needle stick or again blood splashed in your mouth or your eyes or a cut, just seek medical attention just immediately and just follow your post-exposure protocol. Prevention always starts with the proper personal protective equipment, with awareness, and just vaccination for Hep B. This is one infection where really preparedness is truly going to save lives, including your own. Now, meningitis, okay? So meningitis is the inflammation of the meninges, right? Which are the protective coverings around the brain and the spinal cord. This infection can be caused by like bacteria or viruses. With bacterial meningitis specifically, especially the meningococcal form, yeah, you got what I'm saying. That's like the most dangerous. It's highly contagious. Early signs can be like non-specific and kind of resemble the flu, fever, headache, fatigue. But the more specific indicators, very stiff neck, you have photophobia, like a sensitivity to light, altered level of consciousness, maybe a rash, like dark red blotches. But that's like highly contagious, and you got to get like your public health peeps involved and CDC and all this kind of stuff. But transmission of this occurs through respiratory secretions. So again, use gloves.